This is eCancer Television reporting from Rome and the Blood Cancer in the Elderly European Expert Forum. Antonio Cherubini, you're from Italy, and also Lodovico Balducci. You were from Italy, but now you're from Tampa, Florida. Antonio, you're primarily a gerontologist, and Lodovico, you're primarily an oncologist. But you came together in this session on managing elderly heme oncology patients. What do you think are the key things that came out of your discussions in this morning's session here in Rome?
I think that the key issues that came out is, first of all, that we need to identify the best trial design to answer the proper questions in cancer and the elderly, because the aging is a very diverse, the age population is a very diverse population, and it is virtually impossible to account for all the variables that are present in randomized clinical trials.
So, Antonio, how is that done then?
I presented a European project funded under FP7 called PREDICT that addressed the issues concerning exclusion of older people from clinical trials. So there is no doubt that we need to push for including these older people in clinical trials from the early phase to the late phase to understand better what drugs or other treatments can do in this population. But of course, it is important also to organize large-scale databases that are adequately powered in terms of data with a collaboration between oncologists and geriatricians to answer questions that clinical trials will never be able to answer.
Yes, indeed, cooperation has been a real key issue discussed here in Rome. How do you think this should be done? In fact, do you think geriatricians should be more heavily involved in therapy for patients who are older?
I think we should change the current situation in which there is very little collaboration between hematologists and geriatricians, and we should work together, integrating. We need a screening, and then after the screening, we need to identify patients who need the comprehensive geriatric assessment by geriatricians, and then we need to work closer with the hematologist and the oncologist that are going to treat this patient and to cooperate for the long-term management.
I agree completely with what Antonio said. From an oncological standpoint, what I would like to see to happen is that the geriatrician were the primary care physician for the older patient. The geriatrician would be responsible, therefore, to evaluate the patient, to see what the patient life expectancy is in each situation, to see what the patient's tolerance of stress is, which means tolerance of cancer treatment, to identify the weakness of the patients that may cause disability at a later time. For example, I had an uncle of my wife who was one of the most prominent anesthesiologists in Italy. At age 80, he was still doing snow skiing, downslope skiing, until he developed a colon cancer, a very small colon cancer. He was operated. When he recovered from the operation, he started falling, and from then on, he has been a completely downslope situation, and right now is practically completely dependent. Was that possible to identify this patient before and prevent him from losing this functional capacity? So that, I think, would be one of the key of the geriatrician work in the management of this patient.
Now, one of the ways of doing that would be randomized controlled trials, but I think you have referred to evidence-biased medicine.
Yeah, unfortunately I cannot take credit of that. I think Dr. Grimley Evans from the United Kingdom said that in geriatrics, evidence-based medicine is evidence-biased medicine. And the reason is because the randomized clinical trials are very important, like Antonio said, to answer some specific questions. For example, a randomized control trial was very important to establish that chronologic age was not a contraindication to tolerate the treatment for lymphoma. But a randomized controls trial exclude the majority of the patient on account of their comorbidity, of their poor function, of a lot of other problems that are the most common problem in the elderly. So they don't tell us what happens on the field. They only tell us what happened in the laboratory of the randomized clinical trials.
And how, though, do you study cancer in older patients?
I think you need to, as Antonio said, you need to have some very wide, worldwide or at least nationwide databases in which all older patients are evaluated in the same way in terms of function, in terms of comorbidity, in terms of social support, and after you've studied hundreds and thousands of these patients, you realize what factors are important.
But we want to convert cancer to becoming less of an enemy. At the moment, it's shaping up to be a really big enemy, isn't it?
Exactly, because we have found ways to fight very efficiently cardiovascular diseases and stroke, and there are studies showing in the last 30 years that we gained almost 5 years of life expectancy by defeating these diseases, but unfortunately it's not the case for cancer. And the people that now live longer surviving a myocardial infarction or a stroke, they will develop a cancer in their future. So cancer is becoming more and more diffuse and still not very treatable.
What are your suggestions?
That we need to concentrate our efforts in order to find not only new therapies, but also new management pathways for these patients.
Now, the two of you are absolutely agreed on cooperating with different disciplines. What's the formula for getting that right?
Well, I would say France is an excellent example because France has already, in geriatric oncology, has already realized that the geriatrician and oncologists work together in virtually the evaluation and the follow-up of every older patient with cancer. I think that that is the way to do it, simply to make sure that every patient age 70 and older has a geriatrician, a trained geriatrician as a primary care physician, and this trained geriatrician is responsible to coordinate all the choices related to the health of this patient.
So could I ask both of you finally to sum up, what are your hot tips for the busy clinician about how best to manage hematologic malignancy in older patients?
Assuming that this cooperation between geriatrician and oncologist does not exist yet, and I think that an oncologist needs at least to be able to realize whether the older patient is functionally independent, that is, whether the older patient is able to survive alone. Second, is independence, the so-called instrumental activity of daily living. Second, to make sure what kind of comorbidity the patient has, and in particular, rule out cardiovascular, pulmonary, renal, and other cancer comorbidity. And third, make sure the patient is getting the right medications.
I think, yes, we need to increase the awareness and the knowledge of the hematologists about geriatric issues and of geriatricians about hematological issues. So the complexity of older patients, I think, does not really allow shortcuts. We need to improve the qualification of both specialties and to start to work together. And there was this morning also the excellent proposal of a formal evaluation of the efficacy of adding the comprehensive geriatric assessment to the usual management of oncohematological malignancies, and I think this is the way forward.
Professor Antonio Cherubini and Professor Lodovico Balducci, thank you very much indeed for joining me here on eCancer Television.
My pleasure, thank you.